but we can go ahead and get started. And thank you everyone for joining. This is the second webinar in a series of sessions really designed to support countries and programs to introduce oral PrEP in West Africa. And this is if we go to the next slide, Aubrey, this is a session that is on the developing guidelines, national guidelines for oral PrEP. This is a follow-on session. The first session was about lessons learned from PrEP introduction across countries. Today's session is the second one, is on PrEP guidelines. And we will be hearing from several panelists, including Michelle Rudolph from the WHO, Joseph Marungu from the Pangea Zimbabwe AIDS Trust for Zimbabwe, Patricia Jaconia from LVCT Health in Kenya, as well as we will actually likely not be hearing from Jules from Mali, given the situation in Mali, but we'll instead be hearing from Chris Okolo from the FHI team. And just a reminder, if you go to the next slide, Aubrey, that this is, actually, I will go over the agenda first. So what we will be discussing today is we will hear from Michelle Rudolph on the WHO guidelines for oral PrEP and have an opportunity to ask questions. And then we'll spend the majority of the session really hearing from participants from different countries who have adapted the WHO guidelines to national guidelines. And we'll be hearing about the different challenges or different ways of adapting the guidelines that they've experienced and what they've actually experienced in practice. And we will have a chance to ask them questions as well. And then we will wrap up at the end. And if we go to the next slide, just a reminder that this series of webinars is being held by the Choice Project, which is an 18-month collaboration funded by USAID in partnership with PEPFAR. And we are a collaboration also between two projects, the EPIC project and the RISE project, both of whom are focused on HIV prevention, especially the scale-up of antiretroviral-based HIV prevention products in PEPFAR countries. And the role of our project is really to support learning and address technical gaps across programs and projects. On the next slide, you can see that we do have a website that you can go to get additional information from the webinars, and also to email us. You can see an email address here. This is also where the registration links will be for other webinars. All right, and with that, I think we can go ahead and get started. As people join, please feel free to introduce yourself in the chat box, and we will continue on. So we shared this framework on our first webinar last month, and it's just a framework that we have been using to really introduce the different aspects that we need to consider for oral PrEP introduction and scale up. And that goes from planning, developing plans and budgets, thinking about the supply chain and distribution, actually engaging in the health system to deliver PrEP, and engaging with healthcare workers, actually engaging with end users and thinking about demand and communications, and then monitoring and evaluation. Today's session will be really focused on the first element, which is developing plans and guidelines and policies to support PrEP implementation. And future sessions will be focused on some of these other topics. All right, so with that, I will go ahead and we would like to actually do a quick poll for those who are on the webinar, asking about whether your country has PrEP guidelines in place. And so you will see a poll come up on your screen. And if you could just click one of those buttons, and then Aubrey, perhaps you could tell us what the results are once people have entered their input. We're just curious to get a sense of where PrEP guidelines are in your countries.
Yep, and I'll give people about 10 to 15 seconds more to vote. Okay, I'm going to end the poll now and share the results.
Great. Thank you, Aubrey. So we can see that we have the majority of participants, their countries are in process of developing guidelines, but also in some good number, guidelines are finalized and launched. We'll really be looking forward to hearing from all of you in this conversation about what the considerations are for those who are in process on guidelines, and then also for those who have finalized and launched guidelines, we'd like to learn from your experiences as well. So we'll certainly be opening up the conversation to discussion throughout this session. So thank you for sharing that. And with that, I'd like to introduce Michelle Rodolph from the WHO, who is going to take us through an introduction to the WHO guidelines and also how she's seen them be adapted across different countries and what some of the different considerations are there. Michelle, I'll hand it off to you.
Hey, thanks everyone. Okay, I'm just trying to get the screen sorted on my side. Great, so I can see it. So good morning to colleagues who are in the US and good afternoon to colleagues in Southern and Western Africa. Or I guess Western and Central Africa. I saw Burundi chat come up. So I work with the WHO, World Health Organization in Geneva, the HIV department, which is now the HIV, hepatitis, and STI department. My focus is on HIV prevention, specifically introduction of pre-exposure prophylaxis in Southern and Eastern Africa historically. Within the last 10 months, we've expanded to looking at expansion of PrEP within Western and Central Africa. I also work very closely with colleagues in the Sexual Reproductive Health Department of the World Health Organization on linking HIV prevention services into family planning programs. Next slide, please. Thanks. So I'm here to talk to you about the WHO PrEP implementation tool. And so I'm smiling because I have all these hand gestures to show you this and that. But anyway, let me move on. The WHO implementation tool for delivery of oral PrEP was developed and released about 3 years ago. There's 12 modules looking at different facets of PrEP delivery. And so what you'll see here in the middle of your screen is some icons which represent the individual modules that are available. So for example, today we'll focus on the clinical module. But for your information, there's also information on monitoring evaluation, delivery of PrEP to adolescents and young people, site planning, working with regulators, counselors, etc. To draw your attention to the module on the bottom in green on testing, that is due to be updated either later this year or early next year to account for the revised WHO testing algorithm. And you'll see on the slide, there's a link to where you can access all of these modules online. And before we move on, I also want to draw your attention to, with this very strong support of JPIGO, there's been this majority of these modules have all been developed into an app and are available on the Android and iPhone platform. This is very easy to access via the same link here. And JPIGO, in partnership with WHO, is also coming out with an online learning tool. They have this available, but this will be updated to incorporate new information on PrEP. Next slide, please. So just to kind of get into the nitty-gritty, in the clinical module, there's not many slides so first to go through, there's not many slides I have here, but They're relatively dense, meaning dense, but they really summarize very well the key points as presented in the clinical module. So what I want to talk about right now is in the clinical module, the beginning discusses how to determine PrEP eligibility and risk. So WHO recommends that these 7 criteria, which I will discuss now, are all present in order to be eligible for PrEP. And this is not the same as for those who want PrEP. This is just to determine eligibility. So for example, people must have an HIV negative test. They must report no past exposure to HIV in the last 72 hours, or that they've been taking PrEP. They must not show or present with any signs or symptoms of acute HIV. Their assessed creatinine clearance levels should be greater than or equal to 60 ml per minute. They can have no reported allergies to PrEP medications and also be willing to take and continue to take PrEP and be retested regularly for HIV. And for the 7th is to be at substantial risk. So at substantial risk of HIV really comes with one of the following. Number 1, and I want to strongly emphasize that a person, a participant, a client comes in requesting PrEP. Many times we've seen frequently in the clinical setting, we've seen that even though someone did not state that they were clearly at risk for PrEP, for HIV infection, the mere fact that someone's coming to request PrEP often indicates, excuse the motorcycle in the background, often indicates that they may not want to share with the clinician or provider what their risk is. For example, in Kenya, I know of an example of a young man coming in requesting PrEP, but not wanting to share with the provider / the nurse who he regarded as an auntie that he's a gay man. So when a client comes in requesting PrEP, that is one reason to provide it. If a person reports having an HIV positive sexual partner who's not on medication or not known to be on medication, if they've used PrEP more than twice in the last year, if they're reporting inconsistent condom use, reporting a sexual partner at high risk of HIV infection, or a recent history of STIs, these are all reasons that come in to account for being at substantial risk. Now, observed adaptations. When we look at eligibility, what we're seeing some countries doing is instead of saying that the HIV negative same-day rapid test, they've used a prior HIV test has been accepted. This can work, but oftentimes we don't know the exact date of when that last test was, or if there's exposure between the last test and when they've come in for PrEP. We've seen that sometimes screening for PrEP, post-exposure prophylaxis, is not done or is done inconsistently. We have seen that the screening for acute HIV signs and symptoms has been done consistently. However, creatinine clearance levels, this is often not tested, or providers have used a urinalysis instead. WHO is reviewing data to assess whether or not this is actually needed. But as for now, WHO still firmly states that the preference is to have a creatinine clearance before giving PrEP. However, the reality is in some countries they don't have the laboratory capabilities. In terms of allergies to PrEP medications, although rarely reported, what we've seen is that it's been consistently assessed. And for number 6, in terms of willingness to take PrEP or be tested for HIV, it's often assumed instead of being asked directly. Now, regarding the last eligibility criteria, there's been a great deal of variability across countries. In some countries, PrEP has been limited to specific populations, for example, been targeted with MSM populations or sex workers or serodiscordant couples, which, depending on the access to ARV medication, may not be the most in need population. Sometimes the screening instruments are used to screen people out of taking PrEP instead of trying to include them. In other words, looking for reasons to not give someone PrEP instead of reasons to give someone PrEP. Sometimes the list of questions are tailored towards local policies, so questions about high-risk sex may not be asked of younger women who are younger unmarried women. And some settings have their practices of requesting PrEP is not sufficient without qualifying or acknowledging what the actual risk is in place. Next slide, please. So for PrEP drug regimens and dosings. So according to the WHO Essential List of medicines, 3 regimens are approved for PrEP use: TDF alone, TDF-FTC, which is the acronym for emtricitabine, or TDF-3TC, which is the acronym for lamivudine. Most commonly used is TDF-FTC. Most of the trials showing efficacy of PrEP use showed greatest efficacy in the trials of TDF-FTC. What we've observed is that countries make their own choices. For example, South Africa, actually, let me use the example of Kenya. Kenya includes TDF-FTC and TDF-3TC in their guidelines. However, TDF-FTC is what is used most commonly. Lesotho uses TDF-3TC, and my understanding, if anyone from Lesotho is on the call, please correct me if I'm wrong, is that this is due to procurement issues because the country of Lesotho has historically already been procuring TDF-3TC for their ARV regimens. WHO does recommend monthly and multi-monthly dispensing options. For example, after the first visit, between the first and second visit, to receive 1 month supply of PrEP, then come back for a retest, and after that receive 3 month supply. However, this varies by country based on supply and policy. WHO recommends daily PrEP for all men and all women and men who have sex with women, meaning 1 pill daily for 7 consecutive days before sex to start, meaning before to be protected, and then 1 pill daily for 28 days after last risky sex. This is generally consistently followed for men and women, and women and men who have sex with women. So the dosing options for MSM are a bit different. For daily PrEP, studies have shown that for MSM, both daily PrEP and event-driven PrEP are both effective. So for event-driven PrEP, I realize this on the bottom, but I'm going to speak to it first. And what you can see on the right side of your screen is a WHO technical brief that's out discussing, calling what's the 2 + 1 + 1. And we use the term 2 + 1 + 1 to describe the dosing options for event-driven PrEP. It is only recommended for MSM, for men who have sex with men. And this comes from studies that have only been done and shown efficacy among men who have sex with men. And the dosing option is 2 pills, 2 to 24 hours before sex, and then 1 pill 24 hours after sex, and another pill 48 hours after sex, or to be translated as 2 pills before sex, and then a pill once a day after sex. This has not been widely rolled out in low and middle income settings. It is being taken up in Europe and in the US. For daily PrEP, for MSM, we're seeing, because we know the 2 pill loading dose works, we're not recommending 1 pill daily for 7 days before sex. We know that the 2 pills 2 to 4 hours before sex, and then we recommend one pill every day until, I'm reading the slide and what I want to say doesn't exactly match up. So for the daily, it's 1 pill every day, as long as you're having risky sex. And then after risky sex stops, then 2 pills after the last risky sex. And the reason daily PrEP can work for some MSM is because they're having risky sex 2 or more times a week. And so when you do the math, which I'm not going to lay out here, it ends up working out to be daily PrEP. And majority of countries are using daily PrEP for women, for heterosexual men, and for men who have sex with men. Next slide, please. So initial visits. So we described the eligibility screening, and as we talked about, this varies based on settings. WHO recommends very strongly to have a Hep B surface antigen testing for people coming in for PrEP. Now, before I speak about the vaccination, the big reason for Hep B surface antigen testing is that if somebody does have hepatitis B, having hepatitis B is not a contraindication to taking PrEP, but having hepatitis B and stopping PrEP gets more tricky. Because tenofovir and emtricitabine are both treatments for hepatitis B, if somebody starts PrEP, It's taking care of their HIV prevention, and it's also taking care of their hepatitis B. If they stop PrEP, then they could have what's called a hepatitis flare. So therefore, somebody with hepatitis B should not stop PrEP without consulting their provider. In addition, MSM who use PrEP should not use event-driven PrEP. Okay, wait, let me use this again. MSM with hepatitis B should not use the event-driven dosing. Excuse me for fumbling through that. Because the TDF FTC treats their hepatitis, and if they're only taking that treatment erratically, or rather event-driven, it will be an insufficient treatment for their hepatitis, and they could also have a hepatitis flare. So now, as it says here, the hepatitis B testing is largely not done, and this is a gap that we need to work on. For people that test negative for hepatitis B, this is a great opportunity for rolling out hepatitis B vaccination. Now, hepatitis C antibody testing is recommended for MSM, and treatment is indicated. What we're seeing with studies among MSM populations is we are seeing sexual transmission of hepatitis C among MSM. This, again, is also largely not done. So we also recommend syphilis testing and STI screening. This is, we've had a recent paper, technical brief and consultation come out to address that. We're seeing among people coming for PrEP, it's not that people on PrEP are getting more STIs, it's that people are coming from PrEP and the baseline STI prevalence is high and it stays high. This is an opportunity we're missing to test and treat people for STIs, inclusive of syphilis. We also recommend pregnancy testing with counseling and refer, and to take a vaccination history. Again, for the same reasons I mentioned for hepatitis B, this is an opportunity to get people's vaccinations up to date. And finally, comprehensive counseling. PrEP is for HIV prevention. People coming in for PrEP are either assumed to be at risk for HIV or know they're at risk for HIV, and PrEP's not for everyone. For some people, they may come in and want PrEP and say they want PrEP, but realize it's not for them. And this is an opportunity to provide information about condoms, lubricant, to provide information to men and women about gender-based and intimate partner-based violence, and also an opportunity to provide counseling and resources on substance abuse and mental health. What we found is that this is inconsistently documented, although PEPFAR does require screening for gender-based and intimate partner violence. Next slide. So elements of follow-up visits. WHO, what we state in our guidance is that we would like people to come in for visit 0, come in 1 month later to 1 month later to check that they're still HIV positive, to retest for HIV that they're still HIV negative, and to also check in on how adherence is going, if there's any issues with taking the PrEP treatment. It's also an opportunity we also recommend that when somebody stops PrEP, that they come in before they restart PrEP again. I can speak to how we define the stopping and restarting later. This is not included for MSM on event-driven because they should be tested quarterly for HIV PrEP. They should be tested quarterly for HIV, regardless of how often they are or are not using event-driven PrEP. What we have found is that the retesting at 1 month post-start is variable. It's not happening in all settings. In terms of assessing for side effects and adherence counseling at every visit, we recommend this, and we've seen that it's consistently assessed. For creatinine clearance, we suggest a retest every 6 months. And as I stated before, some countries are not doing this at all. And then regarding screening or testing for STIs every 3 to 6 months, again, this is variable. Next slide, please. So on to PrEP for pregnant breastfeeding women. WHO has looked at this in detail, and we've determined that daily oral PrEP is safe, may be continued in PrEP clients that become pregnant or start breastfeeding. Not written here, but we also see no reason that somebody cannot start PrEP while they're already pregnant or breastfeeding. We have we know now that women who are pregnant and breastfeeding are at increased risk for HIV acquisition. So in some settings, it may be very important that women who recently become pregnant, depending on their own situation, have the ability to start PrEP if they so choose. Observed adaptations. What we're seeing now is that I'd like to correct this slide because based on my understanding, most countries consider PrEP to be safe for pregnant and breastfeeding clients. At one point, South Africa did not approve PrEP for women who are breastfeeding or pregnant. But as far as I am aware, through colleagues there and partners at the Ministry of Health, that's no longer the case. In terms of pregnant and breastfeeding women being at greater risk than non-pregnant women for HIV acquisition, this has not been acknowledged or rolled out across the board. So many countries don't provide integrated PrEP into their family planning services or into their antenatal care or postnatal care. This is something that the WHO will be looking at in the next year with colleagues from Sexual Reproductive Health Department. Next slide, please. And so just to give some guideline topics here, I'll just kind of skim through them because you can all read them yourself, is, when we look at other national guidelines that are looking at PrEP, they look on guidance at offering PrEP, effectiveness, the minimum package. They look at what we should look at as an indicator for initiating PrEP, contraindication of PrEP, visit schedules, counseling messages, for example, education and counseling, the risk reduction counseling, how to follow up clients regarding stopping PrEP and restarting PrEP, and how to manage clients in specific situations. For example, what to do if a client has an elevated creatinine, what to do if a client does seroconvert to HIV, and how to manage side effects. And then something else we're looking at closely, rather that countries discuss, is who can deliver PrEP and where. For example, the role of nurses and other healthcare providers in the delivery of PrEP. And I believe that's my last slide. Any questions? Yes. I saw some questions pop up in the chat, but I have to admit I wasn't reading them as they came through. I hope I stuck to no, I didn't check. Sorry about that. I'm sorry.
No problem. Michelle, thank you so much for going over that. And I'd really welcome, we do have one question in the chat that I'll ask you about, and then would love to welcome perspectives from across the different countries that we have represented on the phone, from participants from different countries, to weigh in on how they've been thinking about the WHO guidelines and weigh in with any other questions they have. So the first question that we have is around how to stop daily PrEP among heterosexual women and men, and what the guidance is for that.
Okay, so I think I saw that. That was Gaston. Hi, Gaston. The guidance to stop daily PrEP for heterosexual women and men who have sex with women. The official guidance, like with PEP, post-exposure prophylaxis, is after last possible exposure to continue PrEP for 28 days. And it's the same with, I hope I said PrEP, to continue PrEP for 28 days after last possible exposure. Is the same for PEP. And that is, as stated, to take PrEP continually for that 28 days. We do know anecdotally that that doesn't always happen. And there is, unfortunately, there is no data, and likely will not be any data saying what is the perfect measurement. So what I would say to a provider on this call, that you recommend to your client that they take PrEP continuously for 28 days, and you acknowledge they might not. And I officially cannot say anything other than that. So apologies.
With others, would anyone else, and we have participants on the line from Nigeria, Togo, Burkina Faso, and Burundi. Of course, our partners from Kenya and Zimbabwe as well. Would anyone else like to share any perspectives on guidelines or questions that they have? And if so, please go ahead and unmute your line. You should be able to do that directly. Okay. Um, if no one would like to share a perspective or a question, please feel free to add them to the chat or to raise your hand. And if you're having trouble unmuting your line, we can certainly do that for you. I'll give it just another second to make sure that we don't have any further questions or reflections.
I see from Jerry Guama. I'm going.
Yeah, you're right. This is Jerry
Yeah.
Graham from Nigeria. So we are in the process of developing a national guideline, and what we have had is what PEPFAR had developed initially, and again, it was limited to just for key populations and serodiscordant couples. So that was the situation that it was at initially with PEPFAR. In Nigeria. Then now we're thinking about including the target population. Expanding the target population to include high-risk adolescents as well and some other settings. So that's why there is going to be a review to make it a national guideline. So there's something I saw over in the presentation that had to do with the creatinine clearance and why somehow it's not adopted in many places. Usually for us in Nigeria, we actually thought to go with it, but then the cost and also availability was a limiting factor. So we had to go with urinalysis as a first screening so that if there is any material finding from urinalysis, then we can escalate further, and so that we don't waste a lot of resources, because there isn't that much in terms of resources for the clients to spend in terms of getting creatinine clearance. And of course, as I said, it's not widely available across locations in the country. It's only in some tertiary facilities that you may get that, or some very high level secondary facilities. So that's why we had to go with urinalysis as a screening test first. So I don't know if that is fine, and if you would want to say a word or two about that.
Could I reply to that, Niraja? Great. So Jerry, thank you. It's nice to hear from Nigeria, and it's nice to hear that you're working on building your PrEP program. I have 2 points to make. The first point is I suggest that we find a way to link you with colleagues from Kenya, because I do know in Kenya they're not doing creatinine clearance across the board. It is recommended, but for the reasons you just cited, it's not being done. I'd also like to link you up with some colleagues in South Africa, because I know the Ministry of Health under our colleague Christina, and with colleagues at WHO have recently done a review to understand if they really need to do the creatinine clearance, because it is costly and it is difficult to implement. And I know that what I've seen in other settings, and also from that creatinine may be to do this creatinine clearance screening may be most strongly indicated for clients who have known kidney problems, have diabetes, or are of a certain age. And I'm going to say conservatively that age is over 40, 45, but it might be higher. And in 2021, WHO is revisiting our recommendation on creatinine clearance. So perhaps we can be connected offline, that I can share this information with you to help you in making these decisions. Thanks, Jerry.
Michelle.
Thank you for sharing. Oh, go ahead, Katie.
Oh, yeah, sorry. I just wanted to let everybody know that we do have Patricia Jaconia from LVCT Health in Kenya on the phone, and she could share a little bit of their experience with using urinalysis, I think. Patricia, are you available? Are you on?
Hi.
Hi, I know
Hello?
I know you'll be presenting on this coming up next, but maybe you want to just add to the urinalysis discussion and the use of that in Kenya now while we're talking about it.
Sorry, Katie, just repeat.
Sorry, the question was about urinalysis and the use of that in lieu of creatinine clearance testing to ensure that resources aren't wasted, and how that is being done in Kenya. Michelle just mentioned that Kenya and South Africa are still doing that. Mm-hmm.
All right. Yeah, so for the Kenyan case, creatinine clearance is not a requirement at the point of initiating someone on PrEP. So what we have done as a country is to follow up on clients to ensure that creatinine clearance is done at least within the first year when someone is enrolled on PrEP. So the quarterly follow-ups every time the client comes to the clinic is currently what is going on, and to ensure that before that year ends, the client has at least done the creatinine clearance. And we've seen that really help us with the uptake of PrEP, since the test is not readily available in all facilities.
And are you using urinalysis as a proxy at all earlier on, or any as an initial screening method?
Sorry, Katie, I keep losing you. I don't know if it's my network.
Sorry, I was just wondering if in Kenya that urinalysis was being used in the initial stages before the creatinine clearance test could be done, or if you're not using it at all. Maybe it's my line.
Can I? This is Chris. Can I respond to that, Katie?
Sure.
Yeah, because we also have a program in Kenya, and we're also offering PrEP. And I know that we're not using urinalysis at all. So in Kenya, creatinine clearance is not a requirement, like Michelle mentioned. It's not a requirement at all. It's recommended, but generally people don't even do it. So within our program, we really don't request, creatinine test at baseline, and we don't use urinalysis. But I also wanted to support or to share additional experience from Nigeria, and just to confirm what Jerry just talked about. In our program in Nigeria, we're currently using urinalysis, and any individual with albuminuria or protein in the urine are the ones that will now send for creatinine test, just to be very sure that this is not due to kidney damage. Although we know there are other reasons why somebody will have protein in the urine, but particularly albumin is more sensitive than just looking at protein in general. So any individual who has abnormal or who has protein in the urine are the ones that will now send for baseline creatinine. But generally we just use the urinalysis to screen all individuals, and anyone without protein in the urine is initiated on PrEP. And I think this is very important, particularly as we're trying to scale up PrEP, including PrEP initiation at community-based sites. It becomes more important for us to look at the eligibility criteria, because having creatinine is continuing to be, or has continued to be, an impediment, for initiation at community-based sites, on mobile clinics, during outreaches where you cannot do all these tests. So, and again, another experience from other countries like Eswatini, Malawi, where we're actually doing creatinine, we've seen more than 90% of the clients actually have normal creatinine clearance at baseline. So I think if we're able to get more evidence suggesting that baseline creatinine may not be absolutely necessary, that will actually encourage and help ensure uptake of PrEP, while we can now start focusing on making sure that creatinine is checked maybe after 6 months or at least once a year, particularly for those who are at high risk of developing kidney diseases, or people who have comorbidities that will make them develop kidney disease. So these are some experiences from our programs. Thank you.
That was helpful, Chris. Thanks.
And we'll be talking about this more in just a moment, and we'll also hear from our colleague Joseph from Zimbabwe about how they manage creatinine clearance. Before we move on, I just wanted to also ask, there's one more question in the chat, Michelle. Oh, did you want to add something? Oh, okay. You were just going to ask the same question. There's a question here about, is it mandatory to screen clients? I think this is Hep B, but please correct me if I'm getting that wrong, but for Hep B, and to vaccinate negatives before placing, before they are eligible for PrEP.
Somebody adding something in? Is that Rosalie?
Yes, could you
Maybe
get a little
didn't.
closer to the
Cheka?
Oh, sorry, not you, Michelle.
I think that was background, Nirja, and I muted the line.
Oh, okay, got
Well,
it.
I had some background that I could hear, so excuse me, from my own house. So I apologize. I can't. I'm going to try to pronounce your name, Ibichol. I'm so sorry if I didn't get your name correct. So regarding screening for hepatitis B and vaccinating negatives, no, it's not mandatory. But I am going to guess you're from Nigeria, but I'm not sure from your name.
Yeah.
But
Yes, it's the EPIC team in Nigeria.
okay, thanks. But
Sure.
what I would suggest is, no, it's not mandatory, but it's highly advised. And for the reasons I cited, if you put somebody with hepatitis B on PrEP and then they're taken off the PrEP, they could have a hepatitis flare. And in terms of that mandatory vaccination, it's not mandatory, but in my perspective, I look at it as an opportunity. I honestly, I apologize for not knowing what the cost of the test or the cost of the vaccine, although I do understand the cost of the vaccine is relatively low. But what I would say is if there are issues with resources or be it financial or human resources, that this decision be made on a setting by setting based on what you know of your population. Now there's been more funds put towards hepatitis. So in the setting in Nigeria you're working, my suggestion would be to get an assessment of what the background hepatitis B prevalence is and look at the populations that you're working with and see if you can find data on hepatitis B prevalence in that population. And you may find that it's actually quite high and it's worth putting those resources towards. I hope that helped. And yes, Gaston, they do need to, that's correct. I'm going to read it out because it's here in front in case others are missing the chat, that hepatitis B, having a hepatitis flare is not associated with having symptomatic hepatitis B infection. Thanks for pointing that out. Okay, over.
Great. Well, I'm going to move us along, but please continue to add questions to the chat. And Michelle will be here with us, and we will also hear from some of our other colleagues who have helped to adapt the WHO guidelines to national guidelines. So please keep adding questions to the chat. We're going to hear from our colleagues, Patricia, Joseph, and Chris, on experiences from Kenya, Zimbabwe, and broadly from West Africa, on experiences adopting the WHO guidelines into national guidelines. We'll touch on a number of the topics that just came up, but please continue to add questions to the chat, and we will come back to a group conversation in just a few moments. And Patricia and Chris, if you are able to be on video, please feel free to turn your video on. If you are not, then that is okay too. But why don't we go ahead and go to the next slide. We've asked our colleagues across countries to speak to three major questions that we know have come up for a number of people and have already come up on this call. So the first one is, who is PrEP for? And how do you design guidelines around that include this question of who is PrEP for at the highest level? Then the second question, within the broad populations that PrEP is for, how do we determine who's eligible or ready for PrEP? And this is where we'll talk to a lot of what tests actually are done, which ones are done within the year, and how countries really consider those questions and balance that with the resources and the realities on the ground. And then the third question is, how is PrEP initiation follow-up conducted? So we will ask our panelists to talk through these three questions. And if we go to the next slide, Patricia, would be great if we could start with you and then go to Joseph. So Patricia, for Kenya and Joseph for Zimbabwe, in your guidelines, who is PrEP for? What is that defined as? And how did you decide who PrEP was for in the guidelines?
Thanks, Niraja. I really hope you can hear me. Sorry, my network keeps on fluctuating. So could you just confirm you can hear me?
Yes, we can hear
Yes,
you.
we can hear you well.
All right. Okay, thank you. So in the Kenyan context, PrEP is for people who are at substantial ongoing risk for HIV. And our decision to make PrEP available to everyone at substantial ongoing risk was done in around 2017 when we were thinking about the national rollout of PrEP. And this was after we had done demonstration studies, and we knew already that from the demonstration studies, we had some that focused specifically on sex workers, others focused on the MSM and adolescent girls and young women. And we had already started getting complaints, especially from communities, why PrEP was being made available to adolescent girls. And so to be able to address issues of stigma around PrEP, we decided at the National Technical Working Group to make PrEP available for anyone at substantial ongoing risk, so that anybody who felt they were at risk and PrEP would work for them would feel comfortable to access it, so that it is not seen that it is for a specific group of people who are promiscuous, as that was going on in the communities during the demonstration studies. So that was when we made that decision. And in the actual practice, you will find that PrEP is readily available for all the key populations. And for us, the key populations are the sex workers, both male and female, men who have sex with men, and people who inject or use drugs, and transgender persons. And it's also in practice available to adolescent girls and young women, and mostly within the DREAMS project, and also for serodiscordant couples. Thank you.
Joseph, would you like to go ahead?
Thank you, Niraj, and hello everyone. In Zimbabwe, we launched our guidelines in 2016, and almost similar to Kenya, PrEP is for all clients testing HIV negative and at high risk. And our criteria for high risk is defined by the screening tool, which I'll talk about later on. However, having said that, the guidelines also go on to highlight priority groups. So the priority groups were selected and identified based on the local epidemic patterns. So we had just come out of a number of surveys, including the Know Your Epidemic study, hotspot mapping, as well as surveys, including the FEAR study in Zimbabwe. So those were the various sources of information that informed the priority groups listed, which include female and male sex workers, serodiscordant couples, adolescent girls and young women. And then we have a bracket for high-risk men. So that includes men who have sex with other men, prisoners, and long-distance truck drivers. We also have transgender people. However, having said that, the guidelines also go on to say anyone else who's at substantial risk based on the assessment, but also perceives him or herself to be at risk, should be offered PrEP. Thank you.
Great, thank you both. And maybe we can continue on, and then Chris will come to you after these next few slides. So continuing on, I think both of you mentioned that in the guidelines, PrEP is for anyone who is at substantial risk. And then there are other requirements for eligibility, and then ways that you assess risk. And so maybe we can go on to the next slide, Aubrey, and talk through eligibility or readiness for PrEP and how you have adapted the WHO guidelines in practice. So Patricia, we'll start with you again and then go on to Joseph.
Thank you. So in the Kenyan context, we adopted the WHO guidelines, where of course one has to test HIV negative, and then creatinine clearance is recommended, but as I had mentioned before, at least it has to be done within the year. But what we've also seen in practice is that people don't necessarily go for the creatinine clearance tests. And also the fact that somebody does not come with the creatinine clearance even during the course of the year, it should not delay initiation or continuation on PrEP. And in practice, as I've alluded to before, is that a lot of providers don't even follow up to see whether somebody is actually getting the tests. And this is due to a number of reasons. And one of those that we have observed across is the pressure to meet targets. So at the beginning of every year, and because we know targets determine like how much an organization or a country gets in terms of PrEP provision, then what we have seen is that there is more pressure to get the numbers of people on PrEP, and often the providers will not ask the clients about even their willingness to take PrEP, because for us also willingness is one of the indications that you can actually put someone on PrEP. But because providers then, due to that pressure, they end up not asking. So we have a lot of people being initiated at the beginning. But then as the months go by, especially like after the first or second month, we already have a 50% drop off, and that then continues. And then also supervision and continuous support is really required to ensure that providers adhere to the guidelines. When we did, under the Options Project, when we conducted the Knowledge, Attitudes and Practices study, what we realized is that most of the providers did not even know what existed in the guideline, yet they were required to offer PrEP. So that really pointed us to the reasons why sometimes we were having issues with the following up of clients, even documentation, because providers were not aware of what the guidelines required. So that is a key recommendation, and countries should really invest in supervising providers and disseminating the guidelines. And also in public facilities, we realize that screening for renal disease is often not available, and as a result, it's required, as I said before, that at least during that year it is therefore done. So there's a lot of lab networking also that's required to make this test a reality whenever a client requires to take the test. Yeah, thank you.
Thank you, Patricia. Joseph, could you add from the Zimbabwe perspective?
Thank you, Niranja. So from the Zimbabwean perspective, we have, in terms of eligibility, there are 4 mandatory things that have to be done to determine eligibility. So the person has to be HIV negative. And in terms of, so the guidelines do say that it's preferable to have an HIV test result from the same day. However, so that's what the PrEP guidelines say. However, we also know that from the HIV testing services guidelines, we also know that a test result is also valid for a period of 3 months. So in practice, you will find that not everyone is initiated based on the same day test result, especially those that are also not ready to be initiated on the same day. Yeah, as long as the test result is documented and still falls within the 3-month period, then it will still be valid. And then we also look at ruling out acute HIV infection. So if there are any signs or symptoms of acute HIV infection, then PrEP has to be delayed. And then if a client also experienced exposure in the past 72 hours, then PrEP is initiated, and then the patient can then also, the client can then also be reassessed for PrEP at a later stage. Then we also look at the non-medical aspects. So we are looking at commitment to adherence and follow-up. Very important. So these are some of the things that I discussed when we look at readiness to ensure that the client is actually committed to adhering to PrEP and the follow-up schedule. However, what we have noted is in as much as we emphasize a lot on the follow-up schedule and also an exit visit, based on the 28 days after last exposure that was discussed earlier on, it's very difficult for clients to come in for the exit interview. And then we also look at, when we look at readiness, we also look at other counseling elements, including making sure that the client has a basic understanding of PrEP, what PrEP is, how different it is from ART and from PEP. We also emphasize a lot on combination HIV prevention, commitment to adherence, and then we also discuss other key elements, including pill storage and also issues to do with disclosure of PrEP use. Yeah, so those are some of the elements that we consider when we look at eligibility and readiness. Creatinine is not mandatory at initiation, and neither is it mandatory at follow-up, given the challenges that we have in the system. But we have also reviewed from projects that have been conducting creatinine on a regular basis, 6 monthly, based on the national guidelines. We have noted that the incidence of abnormal creatinine at baseline as well as at follow-up is very low, and so it's not cost effective. So we tend to depend more on clinical assessment and clinically driven lab monitoring. So we focus on signs and symptoms of kidney problems as well as other risk factors to prioritize those that then need to have a creatinine test at some point. Thank you.
Great, thank you both. And I might move us along here to go quickly through the next two pieces so that we can open back up for discussion amongst the participants. So on the next slide, could you just quickly talk to how you do risk assessment in Kenya and Zimbabwe for PrEP initiation? Patricia, we'll start with you.
Yeah, thanks. So for the risk assessment, we have a very comprehensive tool that is utilized in the facilities, and very clear guide in the national guidelines on what to be able to probe for. So among some of the questions that we have in the guideline is more linked towards sexual behavior. And this looks at condomless sex, like if somebody has had unprotected sex in the last, I think it's about 6 months, and if somebody is engaging in transactional sex, has a recent history of sexually transmitted infection, has recurrent use of PrEP, also the number of sexual partners, if somebody has had sex under influence of drugs, sex with partners of unknown HIV status, or the status could be known but the person is not yet on ARVs, or has not attained viral suppression. We also look at the history of gender-based violence, because again, what we realized is that especially for women and adolescent girls, there were continued reports of gender-based violence when they started using PrEP. So it became an issue of concern that it's something that we probe for now, and also recurrent STIs also are part of the questions that are asked. So the tool is administered by the provider, and it's discussed with the client to be able to establish all these indicators that would actually help the provider make a decision on whether to give PrEP or not, and this has to be agreed with the client. And in terms of challenges, what we have realized across board is documentation of risk is a challenge. There's a huge gap. So when we go through like the client files, we usually don't get the risk assessment tool put within the file. So that has been a major issue, because even as we go back to just try and understand why someone would start PrEP and then stop it immediately after a month, and you go back to the risk assessment tool to be able to determine whether the person really understood their risk. And more often than not, we find that that is missing. And again, related to documentation is the fact that the risk is not reviewed every time somebody visits the facility. So the provider kind of like have decided that your risk is constant. So when you come, they only do the refills and counseling for you to adhere, but they don't actually check whether your risk has changed in any way. So those have been some of the challenges that we have experienced. Over.
Thank you, Patricia. And Joseph, is there anything you would add that's different from what Patricia just shared?
Thanks. Yeah, thanks, Raj. So our screening tool is almost similar to the one highlighted by Patricia in Kenya. So it's simple and pretty straightforward. But also just to add that our guidelines also then include a long list of practical questions that are used to try and qualify the level of risk. Because then part of the management includes risk reduction counseling. So for example, if then a client says he has 3 partners, you also then want to qualify the kind of relationship that the partner is involved in, whether they are also receiving money for sex, whether there is some element of violence or intimate partner violence in there, and so forth. So there's a long list of practical questions included in the guidelines to try and qualify the level of risk. And the idea is then over time to see whether there's improvement in the risk profile as part of the comprehensive PrEP package that is offered. Then the other thing I wanted to add on is that initially, based on the guidelines, the screening process was a separate step. So the patient would, the client would go through pre-test counseling, the testing, and then post-test counseling, then go on to have the risk assessment as a separate process, which became a barrier, not just in terms of documentation, but also it was perceived as extra work. So not everyone then who's testing negative ends up receiving or being screened or assessed. However, there's been a shift more recently in that the risk assessment is now integrated into the post-test counseling, and that's a more efficient process, but the challenges with documentation of the actual screening process still persist. Thank you.
Great, thank you both. And then we have one more topic here for Joseph and Patricia to speak to, which is about just the overall flow of PrEP initiation and follow-up. And Patricia and Joseph, I think we've probably talked to a lot of this in our previous conversation, but would love just to give you an opportunity to highlight anything else that we should talk about here that we haven't mentioned so far.
All right. So I'll just pick out maybe specific things that would be important, especially in follow-up of PrEP clients, because it's something that we've also observed at country level, that it's a major challenge, especially after the 1 month when the client comes back and then you have to do it like every other 3 months. We have really lost a lot of PrEP clients in that process. And a few things that have been pointed out is being able to decide at what point does the client need to see a counselor, so that it's a counselor-led session, and at what point they need to have like a clinician-led session. So, and especially for subsequent follow-ups, the counselor is extremely important in that process, to help the client and even be able to address other psychosocial and underlying issues that may require the attention of the counselor and may also affect how somebody takes PrEP. And also the risk review. And this, for me, is also something that currently I'm very passionate about, especially because of the adolescent girls who kept on coming up and saying, over time, because of also the risk reduction counseling, my behavior has changed. But every time I come to the facility, the provider still insists I need to continue on PrEP. So being able to emphasize and build the capacity of providers to be able to conduct this risk review and give the client alternatives. If somebody feels they cannot continue with PrEP, what's the other alternative that exists for them, so that it's a client-centered approach? And when the client then feels they want to come back on PrEP, I've realized that they would easily come back if the approach was more holistic than if you only insisted on them taking PrEP for the sake of a target. And lastly, for continuation, for discontinuation, this is the other place that we've seen challenges, because when a client comes and says they want to discontinue PrEP, what we have seen is the providers, like pushing them to just continue taking, you'll manage it, but being able to work with that client when they say, I want to discontinue, and give them the right information that for us within our guideline, you're required to continue for 28 days from the last exposure. So that 28 days is a tough journey for somebody who already decided they want to stop taking a certain product. So the provider even being able to follow up within those 28 days, are you still on PrEP? Now, can we give you another alternative? Like even when they're coming for that discontinuation, you give them, probably if condoms is the best thing for them, you discuss it with them and give it to them. So I think generally around the actual practice, there is more that's required. The guidelines are very clear in terms of what happens at each of the visits up to the 36th month. But beyond that, now the actual practice, we need to really push for a client-centered kind of approach. Thank you.
Yeah.
Thank you, Patricia.
Yeah, in Zimbabwe, the guidelines are also very clear in terms of the follow-up schedule and what needs to be done at each and every visit. But what we are picking up is that in practice, there is variation, mostly because the providers are trying to be responsive to the needs of the client. So you then tend to find a mixture of follow-up schedules. So because of the individualized approach, especially targeting some population groups that like adolescent girls and young women, which is also a good thing because it enhances continuation, but it also creates a monitoring nightmare, because then when you are trying to run your cascades and your outcomes, you then have different follow-up schedules. But generally, it's a good thing because it enhances adherence. Our PrEP current over the last 2-3 quarters has been averaging about 40%. So there's continuation regardless of time on PrEP, which is on the low side. But what I wanted to bring out is that besides the individualized follow-up approach, peer-to-peer support is also very important. So even though our average PrEP current is at 40%, you find that in areas where we have PrEP ambassadors for adolescent girls and young women, we tend to have better continuation rates and higher PrEP current rates because of the peer-to-peer support that's provided that facilitates continuation. And then for clients discontinuing PrEP, they're encouraged to attend an exit visit, which is also a challenge, not just because of the experiences at individual level, but generally within the community. They know that if you try to discontinue ART, for example, the nurses and providers are not happy. So people then tend to shy away from coming back to the facility because of such issues. So this is where the counseling and support becomes very important, as well as the peer-to-peer support. So I think trying to tailor make the service delivery model to the needs of the client is very important. So that you get to understand the issues and the challenges that the clients are facing over time, but you also try to make your service delivery model responsive to their needs as well. Thank you.
Thank you, Joseph. And I'm going to invite Chris to really give us some perspectives across countries, and especially for West Africa. West African countries, to how we could interpret some of these different considerations for West African countries, and what countries can keep in mind if they're continuing to develop their guidelines or if they're revising their guidelines. So Chris, I'll pass it on to you. And I would also ask for all of our participants, if you have something that you would like to share, please add it in the chat or just raise your hand. And we'll open up for discussion right after this. So Chris, I'll pass it on to you.
All right, thank you very much, Nira. I hope you can hear me. So I think the task is very simple and very straightforward. Can you go to the next slide, please? So these are just some considerations for countries within West and Central Africa as they continue to make efforts towards developing their guidelines. I think from the survey that was conducted earlier, quite a number of countries are in the process of, maybe finalizing their guidelines, and some are just beginning, and some, are probably not even started. So based on some of the discussions we've had today, these are some general considerations that countries need to keep in mind as they finalize or as they begin development of their guidelines. And I think the first one is on the populations that will be targeted. I think what has come out very clearly, and this is based on experience from other countries, is the need for us to balance and focus on high-risk populations, particularly when it comes to implementation with broader guidelines that are not too restrictive. We've seen in a few countries when guidelines were developed or when policies were initially developed, PrEP was generally recommended for certain categories of people, like in South Africa, where they recommended PrEP and started PrEP among female sex workers. So even when the expansion came in place or when recommendations changed and they were now beginning to offer PrEP to other populations like men who have sex with men, adolescent girls, and young women, it was associated with some stigma because people initially thought PrEP was only for female sex workers. So I think countries need to keep in mind that they need to be very very careful when they're developing their guidelines and ensure that they provide broader guidelines that will allow or accommodate changes in policies and programming over time. So when we have more evidence regarding PrEP in other populations, you don't want a situation where the existing guidelines or policies will not allow implementers and even providers to easily adapt some of these changes. So we want something, recommendation be for something that will be broader, that will be able to accommodate future changes when it comes to implementation. I think the other thing that's very important to keep in mind again, particularly I think across multiple countries, a lot of ministries of health, so many ministries of health are very reluctant even supporting PrEP because of the fear that is actually going to promote drug resistance. But I think one thing that we need to keep in mind again is that unless somebody has acquired HIV, has seroconverted, the risk of development of resistance is zero. And I think this is one of the reasons why regular HIV screening is very important, so that we're able to quickly identify individuals who have seroconverted and they are initiated on treatment as soon as possible. And these are the kinds of people that will easily develop resistance when they're on PrEP, unless in situations where, clients actually acquire drug resistance strain from the beginning. Otherwise, the chances of development of resistance to PrEP is very, very, very minimal. So we need to keep this in mind and also try to integrate existing, research and studies, as we continue to gain more evidence or gain more experience in implementation, particularly as it relates to drug resistance, we should be willing to incorporate some of these into our guidelines. The other thing, and I think we've really, really discussed this issue around laboratory testing, we also need to make sure that we're not just focusing on HIV testing. Based on discussions we've had today, we all understand the relevance of creatinine clearance. We all know the importance of hepatitis B. Therefore, as we develop our guidelines, as we implement, we need to make sure that we create room for more tests, particularly those that are relevant, although they are not mandatory, but they are suggested and they're very, very important. And I think I'm going to use hepatitis B as an example. If you have someone who's, who has hepatitis B co-infection or who has hepatitis B infection, and you initiated the individual on PrEP, and eventually the individual decides to discontinue PrEP, you can actually have fulminant hepatitis. So to avoid some of these, it will be important for guidelines to also, as much as possible, capture some of these investigations, but not make them mandatory, but just suggested, so that where they are available, then implementers and providers can actually ensure that clients are able to access some of these services, particularly in resource-limited settings like West and Central Africa. So those tests should not be made mandatory. But we know HIV test is something that's very important and should be mandatory somehow. The other thing is, as we continue to talk about or look at follow-up and monitoring of clients on PrEP, we should also remember that side effects monitoring is very, very crucial. And one of the reasons why people discontinue PrEP is because they are experiencing some side effects. So I think we need to keep this in mind, in addition to ensuring that clients are well prepared to initiate PrEP. As they continue to be on PrEP, adequate follow-up support mechanisms are in place to ensure that these individuals are counseled appropriately, they're supported, and they're encouraged to actually continue taking PrEP, because most of the side effects are self-limiting and they do not last longer than maybe 1 to 2 months in most cases. So monitoring and follow-up is very important, but we should ensure that we also monitor side effects as we continue to develop and finalize our guidelines. So I think I'll just stop here and then we can have further discussion. Thank you very much.
Thank you, Chris. And I see that Jerry has his hand up. Jerry, would you like to share some reflections or a question?
Yeah, actually reflections mainly related to what Patricia spoke about, a little bit about healthcare workers being reluctant to stop, allow clients to discontinue PrEP when they indicate their interest in discontinuing. I think this probably stems from our treatment program, and sometimes healthcare workers treat PrEP clients as if they are treatment patients, because you want to stick to that treatment PrEP core and you want it to grow. And sometimes it's kind of difficult. Sometimes also is mainly because they find it difficult to believe that the client who had this risk exposure, high risk behaviors, have stopped. And the client is saying, I'm no longer having exposure, but then the healthcare worker is thinking differently because maybe they know, oh, this person is an MSM, how can he say he's stopped? This person is female sex worker, why would she say she's no longer at risk? So there are different things like that that come into play. And I really don't know how we can solve those if we do not take time to actually training actually emphasize the need to allow the client to make the decision about risk and whether there is an ongoing exposure or ongoing risk at the time they are talking of. And especially if we don't do that well, we may end up actually losing the clients anyhow. Or at the end of the day, they may stop on their own and not come back, and then they may come back later already seroconverted because they didn't want to come back and tell you that they stopped. So meanwhile, they probably again later re-engaged in risky behaviors. So I think these are nuances that need to be put in into the trainings of the healthcare workers a lot more, so that they know that the client really has to be the one to tell you that my exposure has reduced or I'm no longer at risk at such substantial risk. It's very important to have that conversation, I think. Thanks.
Thank you. And I see that Gaston, you also have your hand up. We just have a few minutes here, but please go ahead.
Yeah, it's going to be very quick. I just wanted to sort of echo what Jerry just said, is that, you know, oftentimes people do not have a different mindset. The PrEP provision should not be like the ART provision. PrEP clients do not rely on PrEP for their survival. ART patients do. So it's not the same thing. So I think we need to make sure that, you know, that nuance is understood by care providers so that, you know, they can provide the right message and afford flexibility to, you know, PrEP users to start or stop, you know, when they feel that they're no longer at risk.
Thank you. And I don't see any other hands up at the moment. So I might just move us along to wrap up today, but please do follow up with us. If you have any further questions, we're happy to connect you to any of the people who spoke today. And we can also, after this call, can share some resources. So please do feel free to follow up with us. If you can go to the next slide, Aubrey. We just wanted to highlight that the next session in this series will be on September 16th, and that will be on developing PrEP implementation plans. So that will be the next session on September 16th. If you have particular questions that you would really like us to address in that session on implementation plans, please add them to the chat box now, or you can email us. Here, I believe you all have our email address. You can see westafrica@prepnetwork.org. And you can go ahead and register for the next session today on the PrEP Watch website that you see here. We will also be sending an email with this link to register for the next session on PrEP implementation plans. And you can also see the upcoming sessions that we have in October, November, and December on PrEP delivery models, demand creation, and target setting and costing. And these were, we defined these topics based on the survey responses that you all provided at the end of our last session. And these were the topics that were of most interest to participants. So we will be talking about those in the coming months. And you can go ahead and register for the September session after this webinar. And just on the next slide, as we mentioned, there will be a recording of this webinar on the PrEP Watch page, so you can go ahead and find that. We will also be sending out an email after this webinar with additional resources. We can share the guidelines from Kenya and Zimbabwe and links to other countries' guidelines. And we will also be sharing a template that can be adapted for your own national guidelines. So all of those resources will be coming to you early next week. So thank you very much for joining us, and please do get in touch with any further questions or thoughts. Thank you.
Thank you, and bye.
And yes, the slides will be shared as well. The slides will be shared as well as the webinar recording. Thank you.
Thanks, everybody. Bye.